would like to call upon Dr. Murida Sharma sir, Professor Emeritus, Department of Shalyatantra, STMC Udupi to take over the session. Welcome sir.
The next is about herpes zoster. Next is about the herpes zoster. I think I am audible and screen is visible. Herpes zoster or shingles is an acute cutaneous viral infection caused by the reactivation of varicella zoster virus. Varicella zoster virus is the virus which produces chickenpox. Now, the differences in the clinical manifestation between varicella and herpes zoster is mainly depending upon the individual's immune status. Those with no previous exposure to varicella virus, most commonly children, develop a clinical syndrome of varicella, where you will have that full-fledged varicella, that chickenpox presentation. Whereas those with circulating varicella antibodies develop a localized recrudescence, that's zoster. Zoster is a minimized or localized presentation of the chickenpox as such. It is the same virus which produces the disease, otherwise there is a similarity. Now, the pathophysiology of this varicella and zoster is in a varicella or chickenpox, there is a primary infection, and then the dormant viral particles, they will remain in sensory nerve roots. See, after the primary infection, once it's apparently clinically cured, some of the viral particles may remain there in the nerve roots for a long time, and they may even replicate if at all the patient's immune mechanisms are reduced due to some external factors. The factors like stress, trauma, or any other immunosuppression, there will be inflammatory response in the nerve root. There will be replication of the viruses, and that creates the inflammation of the nerve roots, and it presents with the manifestation in the skin. Motor involvement is rare but often not noticed. Even if it is present, many times it is not noticed as such. The risk factors which trigger these herpes are immunosuppression like HIV infection or AIDS, or any other immunosuppressive therapy which is generally the treatment for the malignancy, etc., or a primary varicella infection in utero or in early infancy, because in many times that chickenpox may occur even in the uterus or early childhood, and the normal immune response may be decreased at that time itself. Patients who have anti-necrosis factors, or also the treatment with the anti-tumor necrosis factors, also have a high risk of developing these complications of herpes. Immune reconstitution with the inflammatory syndrome, this is another specific condition where the patients may have a loss of immunity, and then there is a inflammatory response, as in case of COVID like conditions. Acute lymphocytic leukemia and other malignancies, they also increase the chances of the herpes. Other diseases which also can have a coexistence or presentation of the herpes would be rheumatoid arthritis, inflammatory bowel disease like ulcerative colitis, chronic obstructive pulmonary disease, asthma, chronic kidney disease, depression also have a relative high incidence of herpes conditions. But how that these diseases can really trigger the herpes is not exactly known, but theory is most possibly they do affect the immune mechanism, and the percentage would be something around the same 2.1 to the same are the percentages as such. The clinical manifestation of the herpes could be under three stages: pre-eruptive phase or preherpetic neuralgia, which lasts for about 24 to 72 hours. Then acute eruptive phase, which lasts for about 10 to 15 days. A chronic phase or post-herpetic neuralgia takes a very long time to resolve, particularly in elderly. It lasts longer than 12 months in nearly 50% of the patients older than 70 years. Now, clinical symptoms which are seen in these phases are the first pre-eruptive phase. The symptoms which are presented could be there could be a sensory phenomena which may initially be felt as pain or maybe certain odd sensations. Many times the patient may have an odd sensation like crawling, feeling like or burning many times over the area or certain area of the body without any visible eruptions, which may last for 1 to 10 days. Average is around 48 hours. 2 days is average time. At times it may take longer. Clinically, the problem would be when the patient has these symptoms for a longer duration. See, if it occurs within 48 hours, when you see the eruptions, the diagnosis of herpes would be easy, relatively simpler. But before the herpes eruption occurs, and when the patient complains of some pain or some odd sensation at a specific area of the body, that clinical diagnosis would be quite difficult. You may have to go for all series of investigations, and when everything becomes negative, you may suspect the herpes, or many times the herpes may be suspected in certain seasons also. Certain seasons also would have some aggravations as such, like varicella season, chickenpox season, summer. That's a season where herpes also will become more. Then they usually many times it's felt as pain, but at times it could be just hypersensitivity, or at times it could be itching. It may simulate headache, or if it is present in near the eyes, the lesions are present near the eyes, it may look like iritis. It may be wrongly diagnosed as pleurisy if it is over the chest, or brachial neuritis if it is over the arm. Even at times it could be confused with the cardiac pain or appendicitis or other intra-abdominal diseases or sciatica depending upon the location. Other symptoms like malaise, myalgia, headache, photophobia, and are uncommonly the fever also may be the other symptoms which could be presented depending upon the location of the lesion. The acute eruptive phase is marked by the typical presentation. Initially it starts with the erythema, patchy erythema, and there will be mild induration. If you palpate, that area will become somewhat firm and in a specific dermatomal area of the environment. So that specific distribution of a dermatome is very characteristic. Most of the times it is unilateral. So when it is limited to one side and the distribution of an erythema seen over a dermatome area, you may have some diagnosis of herpes. Lymphadenopathy also may be seen at this stage initially, or maybe in the later phases, lymph nodes also may be enlarged. But usually they are not very huge lymph nodes. Moderate size lymph nodes could be enlarged and they may be palpable in the draining area. Herpetiform vesicles, which are present in the group form, would be the classical presentation over a erythematous base. Cutaneous findings gradually appear unilaterally, and the typical distribution is that will be stopping abruptly at the midline and covering that specific dermatome. That's very important. Gradually, that erythema becomes vesicular. Vesicles initially are clear, then they become cloudy, rupture, crust, or involute. So initially they will be very clear fluid containing eruptions. Later on they may become cloudy and they may rupture, even a crust formation, hard formation can occur. Then after this phase there will be a gradual resolution. The eruptions, they will subside, and there will be only the erythematous flakes will be seen, and they could be seen as a hardened scale as such. Scarring can occur. Usually it doesn't scar because it's very superficial, but if it's a deep epidermal or dermal layers are involved, there could be a scarring. And many times the complications of a secondary infection would occur, and if there is a secondary infection in these herpes conditions, then again the scar would be quite big, otherwise it doesn't scar much. the pain is typically severe. At that time, the pain would be very severe. Some severe pain along with the eruptions also can occur. Uh, some may be present without pain. Some of the patients may present without pain, which is also called as zoster sign herpetic. Not much very important. Symptoms usually resolve within 10 to 15 days. Complete healing of the lesion may take about a month for complete lesion. The presentation of the herpes eruptions are initially the herpes eruptions are typically clear, then they become reddish, then cloudy, then the crust formation. The different stages of the herpes presentation can be seen. So usually the first 2 days it will be like this only small vesicles which are present over the area, and the surrounding area there will be erythema. Gradually that erythema reduces, the vesicles become bigger, and the fluid gradually becomes cloudy, then it becomes somewhat whitish like opaque, then it becomes crust, that healing like. This is the typical appearance, and a patient may come to you at any phase of that. Then postherpetic neuralgia, that the next phase is the most troublesome phase. It may be persistent or recurring pain lasting for 30 or more days, and after the acute infection, or after all the lesions have healed and crusted also. About in 9 to 45% of the patients, it can, even after the healing, the patient may have that pain, or at times the deep pain is felt after the healing. Then pain is usually confined to the area of the original dermatomal involvement. It's not elsewhere. Pain can be very severe, and pain can persist for weeks, months, or at times years. Slow resolution of pain is especially common in elderly. Older patients, the pain doesn't get resolved easily. Younger patient, it gets resolved earlier. Postherpetic neuralgia is observed more frequently after cases of herpes zoster ophthalmicus. Ophthalmicus is when the eyes are involved, and in instances of upper body dermatomal involvement. Upper body dermatomal involvement like head and neck, the pain will be more severe. Less common postherpetic sequelae include hyperesthesia, or more rarely hypoesthesia or anesthesia in the area involvement. Sometimes it could be like there could be hyper sensation, or at times it could be loss of sensation or reduced sensation. Rarely there could be patients having a complication of CNS involvement or muscular weakness, cranial nerve palsies, diaphragmatic paralysis, neurogenic bladder, and colonic pseudo-obstruction, or wider involvement of the spinal cord producing Guillain-Barré syndrome-like conditions, or transverse myelitis or myositis. Guillain-Barré syndrome and transverse myelitis we will discuss later on in other contexts as well. When the optic system is involved, eyes are involved, there could be severe eye pain with marked eyelid edema, conjunctival, episcleral, or circumcorneal conjunctival hyperemia, reddish discoloration around the eyes and different parts of the eyes, edema of the cornea, and photophobia. When the auditory system, hearing that near the ear is involved, there could be hearing impairment, nystagmus, vertigo, or facial nerve palsy, which resembles lateral palsy. But patients may even the taste sensation may be lost in the anterior two-thirds of the tongue if the facial area is involved. So these clinical presentations are rare; they are not seen quite frequently, but they may produce again confusion with the clinical diagnosis as such. Now, depending upon the forms and other variations of herpes, there are certain names given in neurological textbooks. They will have these different names which may be having some significance from the ICD coding, but otherwise not much significant. Depending upon the location, herpes zoster of maxillary branch of cranial nerve, herpes zoster of mandibular branch of cranial nerve 5, and herpes zoster oticus, that's Ramsay-Hunt syndrome. We have already discussed in the previous sessions. Glossopharyngeal and vagal herpes zoster, herpes occipitocularis, that's vertebral nerves involvement C2 to C3, and herpes zoster encephalomyelitis, disseminated herpes zoster, unilateral herpes zoster involving multiple dermatomes, recurrent herpes zoster involving urinary bladder, bronchi, pleural spaces or gastrointestinal tract, herpes zoster with motor complications. These are the other variations which are not again frequent, but rarely they may occur, and the clinical presentation would be depending upon the location involved and the organ involved. Now, to confirm the herpes zoster infection, in reality, when the patient comes to you with that vesicular phase, that eruptive phase, there is not much of a difficulty in the diagnosis. It's very evident. But still, if at all you have to very confirm that, the investigations which are available are direct fluorescent antibody test of vesicular fluid, or PCR, polymerase chain reaction test, or SANG smear or of vesicular fluid. Now, practically, we do not do any of these tests in the patients. We just make the diagnosis of herpes zoster and then manage. Only in academic interest or maybe in very sophisticated centers, these tests may be done, and the whole course of the test is quite costly and time consuming. Now, the principles of the treatment from the modern point of view, uh, in general, herpes zoster are considered as self-limiting. Even without treatment, they would subside. But to reduce the symptoms, the usual drugs which are prescribed are non-steroidal anti-inflammatory drugs to reduce the pain, wet dressings with the 5% aluminum acetate or baro solution to reduce the discomfort in the area, or certain lotions like calamine lotions are administered as such. Specific drug like antiviral drugs like acyclovir, famiclovir or valacyclovir are mostly prescribed, but practically these would have a very limited role. So I would always contest about that. But the standard prescription is about the antiviral drugs. From Ayurvedic point of view, that's the typical presentation of herpes is that of Visarpa, Agnisarpa, particularly the Pittaja Visarpa. करोति सर्वं गमति दीप्तांगार अवतीर्णवत् यं यं देशं विसर्पश्च विसर्पति भवेत् सः शान्तांगार असिद्धः नीलो रक्तो वा आशुभीयते अन्यदैव स्फोटैः शीघ्रत्वात् द्रुतं सः ब्रह्मानुसारी विसर्पस्यात् अतो अतिबलः स्वतः. That's exactly the description of the Agni Visarpa or Visarpa in Asangazaya. Sushruta has categories. These into three categories are depending upon dosha lakshanas. वातात् विसर्पो वातज्वर समवेतः शोध स्फुरण निस्तोध भेद आयास अर्तिहर्षवान् पित्तात् द्रुतगतिः पित्तज्वरलिंगो अतिलोहितः कपात् खण्डुयित स्निग्धः कफज्वर समानरुको. According to the vata doshas, these are described as such. Now, prescription in general, from Ayurvedic point of view, the most of the patients would have a very satisfactory improvement, and the results are quite good, very dependable. At times it could be considered to be much better than the acyclovir or other antiviral drugs. And my prescription usually is Laghusulsekara, Kamadgaplain and Paripathadikada. Usually 1 week's treatment would be enough. Eruption would reduce, and majority of the patients who are treated with these, they will have lesser chance of the post-herpetic neuralgia. That's what I have seen. Best of the thing is not to apply anything. See, many times people would apply a lot of things over the area, but application often results in secondary infection. Maintenance of the hygiene is more important thing. That vesicles should not be ruptured by itself, and vesicles should be allowed to dry on their own. So, but to keep them clean, that's one of the important precautions. Local applications, LAPAs, like lots of LAPAs are available in the market, and those applied most of the times they increase the chances of secondary infection. If the patient develops post-herpetic neuralgia, I would be considering it as Kevalavata-janya lakshanas, and my prescription would be Sumitsagara Ekangara Saraswata, and the results would be satisfactory. I would not say that every patient would be cured within a short duration. Time, of course, it takes time. Now, whether it is a gradual spontaneous resolution or with our treatment, but the patients would show some significant improvement and resolution in a non-specified time interval. It could be a few weeks, a few months, or at times it could be years together, depending upon the patient's status as such. So that's about the herpes zoster, one of the very common condition, and one of the condition where Ayurvedic treatment often gives somewhat more dependable and better results than otherwise. Now, because we have referred to the herpes zoster, we will refer to the other also, herpes simplex, though it may not be a totally neurological interest, may be considered as something out of that. Herpes simplex is a variation produced due to a virus, herpes simplex virus, which is of two varieties, type 1 and type 2. Type 1 usually presents with the lesions over the mouth and around the face area, whereas type 2 is known to produce the lesions in the genital area. From the clinical point of view, that genital herpes becomes more important, more significant than the herpes simplex of the orofacial disease. As the name suggests, simplex, it usually suggests you of a simple clinical course where the complications are lesser. But the same is not true in case of the genital herpes. Genital herpes can produce a more severe complications, particularly because of the transmission of that herpes during delivery to the newborn, and the neurological deficits developing in the newborn would be of more serious consequence. That's why herpes simplex is important mainly from the obstetrics point of view. Now, as far as the statistics is concerned, around 3.7 billion people under the age of 50, that's 67% of the people, globally have herpes simplex virus type 1 infection, and the main cause is of oral herpes, which is the main cause of the oral herpes. An estimated 491 million people aged around 15 to 49% worldwide have herpes simplex virus type 2, which is the main cause of genital herpes. Infection with HSV2, that's herpes simplex 2 virus, genital herpes, increases the risk of acquiring or transmitting HIV infection. So it's also significant from that point of view. Like the patient may develop AIDS in due course of time. The chances of that HIV infection are very high in the patients who have HSV2 infection or genital herpes conditions. Now, from India point of view, there is an acute lack of data on HSV2 incidence in India. There are only 2 studies among women attending sexually transmitted disease clinics in HIV voluntary counseling test centers in India, and that showed that incidence of 8% and 11.4 cases per 100 person year in Chennai and Pune respectively. Now, WHO is quite concerned with the spread of this HSV and HIV relationship, and one of the universally pushed program is HSV eradication and HSV recognition. But from our country point of view, there is a significant lack of data as based upon these references now, and some central government now is having some program for this HSV screening and the related issues. Maybe in a few years, these programs may be implemented very rigorously. Now, herpes simplex virus is as such, the quality of the virus is it's a neurovirulent virus. That means it has a capacity to invade and replicate in the nervous system. It's one of the neurovirulent virus. Neurovirulent virus means a virus which has a property of invading and replicating in the nervous system. It also has a property of latency. Latency in the sense it can remain silent for many years or a long time. It can maintain latent infection without producing any clinical symptoms, particularly in the ganglions proximal to the site of infection. The orofacial HSV infections, the trigeminal ganglia are most commonly involved. Trigeminal ganglion is most commonly involved, and there is a orofacial involvement. Genital HSV infections, sacral nerve root ganglia S2 to S5 are more frequently involved. They tend to have reactivation and replication of the latent HSV always in the area supplied by the ganglion in which the latency was established, can be induced due to various stimuli like fever, trauma, emotional stress, sunlight, menstruation, etc., resulting in a overt or covert recurrent infection and shedding of HSV. Now, the most important is that shedding of HSV without clinical symptoms also is one of the significant issue. They may get reactivated due to any external factors like any other systemic causes like fever, trauma, or stress also can be a cause for the reactivation as such. So it's unpredictable. If a person has a herpes simplex virus, he can remain asymptomatic for years together. Many times it is not known unless he is screened for the antibodies, and hence that person may have a high risk of transmitting HSV virus to others, and the significance would be when it is transmitted in the pregnant woman, then there will be the risk as such. The clinical presentations can occur as different manifestations. The commonest manifestation of HSV1 is the oral, which is gingivostomatitis, where the gums and the oral cavity is involved. That's the most common presentation. Where onset is abrupt, there will be high fever, anorexia, and gingivitis. The whole gums may become swollen, erythematous, or friable. There could be bleeding from the gums, which is usually sudden. Lesions may occur in the oral mucosa, tongue, and lips also, and later rupture and producing a ulcerated plex. It will be quite painful. Patients presenting with the fever, acute development of the ulcers in the mouth, gum involvement, and painful condition. It's the typical presentation of a herpes simplex oral presentation. And there could be lymph nodes also involved, cervical lymph nodes often are involved, and the skin involvement in the exterior also may be occurring due to contaminated saliva. The usual clinical presentation of such lesions are like this, that you will see multiple superficial ulcers, and the gum of course is involved in such conditions. That's about the appearance of the gyngiostomatitis as such. Later on, it could also be involving the facial area in the exterior also, where there could be excoriation of the skin in the later phases. That's also the presentation of the stomatitis. Then another of the presentation which also is common is a pharyngotonsillitis. Orofacial herpes simplex can present with the pharyngotonsillitis and usually occurs in adults. It presents in the pharyngitis and tonsillitis more than gingivitis. In adults, it's more common as such. Again, the clinical presentation will be fever, malaise, headache, and sore throat, with the vesicles which are ruptured to form ulcerated lesions or greyish X-rays on the tonsils and the posterior pharynx. And there also may be oral or labial, the lip lesions in about 10% of the patients. And it can cause similar symptoms, can be associated with the orogenital contact, or can occur concurrently with the genital herpes. They can occur also along with the genital herpes. The typical presentation of the pharyngotonsillitis, when you look at the pharynx, you can see these kinds of eruptions. Open the mouth and look at the pharynx. These eruptions are seen. That kind of a typical presentation is in case of the pharyngotonsillitis as such. Then herpes labialis is one more of the variation. It's again the common presentation of HSV recurrent infections. When the patient has a previous episode and then again recurs, it's the commonest presentation. And it's also called as cold sores. There would be a pre-presentation or prodromal of pain, burning, and tingling sensation, which occurs at the lip and commonly on the face, around the lips, followed by development of erythematous papules that rapidly develop into thin-walled intraepidermal vesicles that become pustular and ulcerate. And in most patients, fewer than 2 recurrences manifest each year, but some individuals experience monthly recurrences. Most of the times, it presents with the repeated recurrences of localized lesions around the lips and the tongue, mouth, face area, and they may recur at regular intervals. That's the typical presentation of herpes labialis. You will see some vesicular eruptions at the lip area, initially maybe 1 or 2, and then they may heal. Usually they would heal without any symptoms, but there is a tendency for recurrence. You will have plenty of patients presenting with this presentation as such. Another of the presentation of herpes simplex is a herpetic whitlow. Herpetic whitlow is a HSV infection involvement of the finger, as such is called as a whitlow as such. It could be involving the finger as such, presenting along with the genital infections, or maybe along with the orofacial infections also can occur. And at times it is due to, believed to be due to the inoculation from self. So when a patient has a lesion elsewhere, it can just reach to the area and hence produce that. Or it can also be transmitted to dentists or healthcare workers who have a high risk of contamination in the oral cavity of the patients. And similarly, one more is herpes gladiatorum, is the face, arms, neck, and upper trunk being involved, which is often seen in wrestlers or participants in contact sports such as rugby, which also can produce a confusion due to the trauma to the skin as such. But these are comparatively rare. But most common are the orofacial, where either gingivitis or maybe the labialis are the common presentations, or maybe the tonsillitis also may be the presentation. Whitlow, herpetic whitlow can present with these eruptions over the finger area. Nail bed may be slightly involved. Either it could be in the lower limb or upper limb. Most commonly upper limb, lower limb also it can present with the herpetic vitro presentation. These are the typical presentation of vitro. Now these can be considered as spotaka, bispotaka, the kshudraroga. अग्निदग्धनिपाः स्फोटाः सज्जराः पित्तरक्ततः क्वचित् सर्वत्र वा देहे स्मृताः विस्फोटका इति. The usual prescription would be Trifala Lagusukshekara Khadiragishta. Of course, all herpes simplex lesions are considered to be self-limiting disorders, and but the only significance from the contemporary clinical point of view is to identify the latent herpes conditions and possibility of transmission of the herpes to the others. Now, from that point of view, genital herpes has a higher significance. Most genital herpes conditions are more than 85% are due to oral to genital transmission through oral sex, as opposed to genital to genital transmission through sexual intercourse. A sexual intercourse, natural, normal sexual intercourse, has a lesser chance of transmission, whereas if there is a oral to genital contact, that can increase the chances of genital herpes condition. This is about the history. Then incubation period of primary genital herpes is about 3 to 7 days. Range is 1 day to 3 weeks. Constitutional symptoms include fever, headache, malaise and myalgia, and prominently in the first 3 to 4 days. And local symptoms include pain, itching, dysuria, vaginal and urethral discharge, and tender lymphadenopathy. Lymph nodes in the area would be involved as such. The clinical presentation would be starting as some vesicles lesions. Initially it will be superficial vesicular lesions, which may become ulcerative, superficial ulcerative lesions, either over the penis or over the vagina. Initially they present as very superficial vesicles, rupture. Unlike that of the herpes simplex elsewhere, they do not heal completely. Even though they may heal, there would be an apparent very thin skin over which becomes fragile and tends to become chronic. Very chronic, persistent ulcerations could be presented in the genital area, which is a common clinical presentation. And from the clinical point of view, the possibility of genital spread of these infections, they are categorized into 4 categories based upon the clinical presentation: primary, non-primary first episode, recurrent or asymptomatic viral shedding. Primary is typically when the patient's lesions would appear for 2 to 12 days after a sexual intercourse, and usually lasts for 20 days. And viral shedding also lasts for about 12 days. During these 12 days, they have very high transmission of or possibility of transmission, and it can be persisting even before the clinical presentation occurs. During the incubation period also, the viral shedding can occur. So viral shedding usually ceases before complete resolution of the lesion. So even before the ulcers heal, the viral shedding may reduce, and hence a direct transmission chances become less due to the sexual intercourse. But the same is not true in case of a pregnant woman during delivery. Pregnant woman during delivery, even though there may not be a direct viral shedding, the viral transmission can occur to the fetus and the complications can occur, and hence that's important. Symptoms associated with the primary infections may be both local as well as constitutional. Local symptoms are intense pain, dysuria, itching, vaginal discharge, lymphadenopathy, and constitutional symptoms are due to viremia, include fever and headache, nausea, malaise and myalgia. Very important is about more than 70% of the patients during this stage also may become asymptomatic. They may not have any of these local symptoms, but still they may have a primary infection and they may have the viral shedding. Then non-primary first episode infection is a situation where a woman has a heterologous antibodies. The patient had one infection, but the antibodies are persisting. From the clinical point of view, obstetric point of view, this stage is important, because when you do the serological test, the patient may have that viral antibodies, and the patient may not have the clinical symptoms, and this condition is clinical differentiation is impossible. It's only the serological test would confirm this stage. And at present, as per the protocol in India, HSV screening is not made mandatory for a pregnant woman in antenatal care. HSV screening is not yet made mandatory, but maybe in a few years, or maybe as the WHO program is intensified, this also may become mandatory. Now, of course, in the present day situation, in the protocol of antenatal care, there are certain tests which are done as mandatory, but HSV is still not included as mandatory. But in sophisticated centers, they do that test in every patient, and this is one of the stages which is most confusing as such, where the patient may not have any clinical symptoms. Patient may have episodes of that viral discharges and can be confirmed only by the serological test. Then the patient may have another presentation, could be recurrent infections. A recurrent infection, which is most commonly seen, where the patient may have the typical genital outbreak, symptoms of that local eruptions repeatedly, and usually the recurrence rate is quite high in the first 3 months after primary infection, and classically the lesions are unilateral over the one side of the labia, and the patient may have IgG antibodies which are commonly seen as such. Approximately 14% of all pregnant women with a history of genital HSV infection experience recurrent lesions or prodromal symptoms at delivery. This is another of the important issue. Though they may have a latent history, at the time of the delivery, patients develop the symptoms, and that is quite significant, about 14%. And typically, the lesions last for about 9 days and shedding lasts for about 4 days. Then asymptomatic viral shedding. This is another of the crucial issue. Patient may have no symptoms, but they may have viral shedding, usually lasting for 24 to 48 hours, episodes of that. 1 to 2% of the pregnant women with a history of recurrent HSV infection have asymptomatic shedding at the time of delivery, and co-infection with the HIV may increase the asymptomatic shedding of HSV in women. That's about the risks as such. Perinatal transmission of HSV, that's the transmission of HSV to the fetus, is one of the major risks involved and one of the more troublesome issues as such. The HSV is known to be transmitted vertically, that's from the mother to the child during or after delivery, though intrapartum transmission accounts for most of the cases. So it can occur during delivery or after the delivery, and prior to the delivery also is known to that. Maternal age of less than 21 years is a risk factor for vertical transmission. If the age of the mother is less than 21 years, young deliveries, young women becoming pregnant, they have high chance of transmitting the HSV infection. Infection rates, as per the data, statistical data, if the patients have a primary HSV infection, the risk is around 50%. Non-primary first episode infection, risk is about 33%. Recurrent infections, the transmission rate is about 0 to 4% as such. That's about the calculated data based upon the statistics. Then neonatal HSV infections, that's the most important thing. HSV infections which are transmitted to the child, newborn, they may have that typical presentation of disseminated disease where the lesions may be seen throughout the body. Most important and quite troublesome will be central nervous system disease, where the patient may have either meningitis-like symptoms or certain neurological deficits which often produce a confusion with some other neurological deficit, or rarely they may be limited to the skin, eyes or mouth. Mortality has decreased now due to that program of identification of the lesions and maybe the eradication program that involve HSV examination in antenatal care. In the Western countries, it has become a standard protocol, and with that, it is known that statistically the mortality has been decreased to 30% with the disseminated disease and 4% of our central nervous system disease over the last 2 decades. Even now, approximately 20% of the affected neonates will have long-term neurological sequelae. So, once the neurological deficits occur in a newborn, chances of recovery are lesser. Most of the children, they may have to live as mentally retarded or neurological deficit conditions. And hence the standard protocol of examination or confirmation now, the standard guideline, though it's not yet followed in India rigorously, Serological analysis of the blood or CSF, which is for retrospective diagnosis, not for the acute diagnosis. So if a child has a clinical symptom, then these tests may be suggested. Joint preparations of vesicular lesions for confirmation of HSV is particularly neonates. This is another standard protocol. Quantification of intrathecal antibodies. Antibodies also may be studied of CNS antibody response as MRI of the brain in child newborn, CT scanning of the brain, EEG, and lumbar puncture for CSF analysis. PCR is a polymerase chain reactions assay of CSF for HSV1 and 2, and brain biopsy. These are the recommended investigations. Wherever they are necessary, these could be done in newborn. Particularly, this is about the neonates. Neonates developing these HSV infections where they will have lots of confusion with the diagnosis. Child may present with the neurological symptoms like convulsions, movement abnormalities, or other neurological abnormalities where the clinical diagnosis becomes difficult. These series of investigations may be necessary to confirm the diagnosis of HSV. Now, current strategies, that's WHO guideline is like to prevent vertical transmission is with the antiviral therapy, and antiviral suppression for pregnancy with the first episode infection during pregnancy is the most recommended one. Routine antiviral suppression for gravidas with the history of genital HSV, identification of seronegative gravidas at risk for primary and non-primary first episode genital HSV infections, and vertical transmission is reduced with the cesarean section. This is again one of the issues. If the patient is having HSV infection, cesarean may be recommended, and breastfeeding is not contraindicated. If a patient is HSV positive, breastfeeding is not contraindicated. Now these issues are still, this program is still not in the main core practice in India. In the obstetric practice, particularly obstetric practice, this has not yet come to the main core and not yet mandatory as the standard guideline. But in a short period, like within a few months or maybe years, like these guidelines, there may be slight modifications. There could be slight modifications in Indian context because the authorities are now considering these issues. There may be some modifications when it is really presented as such, but this is going to come, and hence we should be sensitive about that. That's about the HSV infection. Now, herpes simplex encephalitis in a child, when it occurs, the clinical presentation would be fever, headache, psychiatric symptoms, seizures, vomiting, focal weakness, or memory loss. Any of these could occur, and they are more common in children than really in the adults. Adults, they are less common experiences, but when they occur, these could be the clinical symptoms which are presented depending upon the statistical percentage, which is mentioned over 90% fever, 81% of the people would have headache, and 24% may present with the memory loss. Rarely which occurs in adults, and then this can be differential diagnosis. And the treatment, standard protocol of the treatment in such conditions would be antivirals and acyclovir or famiclovir are the drug of choice, and to shorten the clinical course. Anticonvulsants like carbamazepine or phenytoin are other treatment. Diuretics like furosemide to manage the increased intracranial pressure, as in case of any other cerebral pathologies. That is the treatment. Of course, we have not seen many patients of that HSV-induced condition. So the other part, Ayurvedic point of view, I don't have much to comment on that. Supportive care in such patients also is included, where airway breathing, nutritional and fluid support, the universal precautions in a patient who has a neurological pathology like prevention of bed sores and bladder, bowel care, etc. Monitoring for increased intracranial pressure and seizures, and admission in a ICU is needed as per the need as such. That's about the HSV infections. With this, we conclude that herpes infection conditions. Next, we will discuss about peripheral neuropathy. I think that we will take up in the next session. So today we will conclude. If there are any questions, we will try to answer, and then okay, there are no questions. So we will conclude today. Next session we will take up neuropathy, peripheral neuropathy.